Hello everyone, welcome to another session of EPAP to Success. Myself, Dr. Joseph Sebastian C., working as a reader at Mar Basilius Dental College, Koramagala. Today, I would like to discuss about classification of anemia and iron deficiency anemia. We will also discuss a short note regarding Plummer-Vinson syndrome. Without further delay, I am directly moving towards today's topic. Anemia. What is anemia? By definition, anemia is a reduction in the total erythrocyte mass in peripheral circulation. The functional outcome of anemia is decrease in oxygen carrying capacity of the blood that leads to tissue hypoxia. So, when we moving towards the classification, we will be having etiological classification as well as morphological classification. In etiological classification, we have three major concerns. First one is chronic loss of blood. Second one is reduced RBC production. Third one is increased RBC destruction. So we will discuss one by one. Coming to first reason, loss of blood. Major reason will be trauma. So it is an acute action. Another reason is chronic type. So there are 2-3 possibilities, that is GIT lesions, some kind of ulcers, gynecological problems. Then we will be having tumors. So this is first thing. Next we are moving towards decreased RBC production. Here we will be having nutritional deficiency, which is comprised of iron, vitamin B12 as well as folic acid. Inflammation mediated iron deficiency. Then we will be having erythropoietin deficiency, which may be associated with renal diseases. Immune mediated one, which comes under aplastic anemia. Bone marrow infiltration type, primary hematopoietic neoplasm, metastatic neoplasm, and endocrine failure, thyroid as well as pituitary failure. That can be the possibilities. Now we are moving towards the increased destruction of RBC. It comprises of so many things. Membrane alteration, both genetic as well as acquired one. Enzyme deficiency, hemoglobin abnormalities, immunological abnormalities, mechanical trauma, infections of red cells, toxic or chemical injuries which may lead to like snake venom as well as lead poisoning. Then we will be having splenic sequestration. So these all are the main etiological factors. Now we are moving towards morphological classification. It's based mainly on RBC size and HB content. So we will be having normocytic as well as normochromic. That means normal shape as well as normal color. Here RBC count will be little bit reduced. So we will be having normal MCV, normal MCH, normal MCHC. So reasons may be hemorrhage, hemolysis, lack of blood formation, dilution of blood with fluids. So this is the schematic representation for normocytic normochromic one, so that you can compare with upcoming slides. Next one is macrocytic normochromic. Here we will be having increased MCV, MCH but normal MCHC, and we will be having lack of erythrocyte maturing factors. So cell size may be large, color may be same, macrocytic. Next one is microcytic normochromic. Here we will be having MCV as well as MCH will be reduced. Normal MCHC will be there. Thalassemia syndromes are the examples for this one. And the picture will be like this. Size may be reduced. Last one is microcytic as well as hypochromic. Here everything will be reduced. MCV, MCH, MCHC, etc. etc. So here example is iron deficiency. So color is reduced, size is reduced. Okay. Now we will be having another set of classification. So broadly, anemia can be classified as anemia of reduced erythropoiesis, iron deficiency anemia, and Plummer-Vinson syndrome, megaloblastic anemia, aplastic anemia, and thalassemia. So today's our topic of discussion: iron deficiency anemia and Plummer-Vinson syndrome. We are moving towards it. It is the most common anemia in the world. So according to WHO, one-fourth of the human population suffers from iron deficiency anemia. What is the reason behind it? As the name suggests, there is a deficiency of iron depletion from human body. So usually humans require iron concentration of 60 parts per million. In this, 70% used for functional needs and 30% is used for storage purpose. Whenever deficiency, we will be utilizing from this 30% of storage. But how we will be having this much depletion? We will discuss what all are the possibilities. Physiological reason is seen on women, that is during pregnancy as well as during other time, menstrual cycle, we will be having loss of blood. So this is one of the major etiological reason. Then another possibility that is applicable for both genders, we will be having epithelial shedding, whether it is oral mucosa or generalized skin. It is the 1 to 2 milligram losses from epithelial shedding is taking place. So how we will be compensating it? It is by dietary intake of 20 milligram of iron per day. So what will be the etiology for iron deficiency anemia? We will be having three broad classification. All these three are interconnected. As the name suggests, dietary insufficiency, inadequate absorption, or increased requirement. So we will be having a discussion about each one. First one is dietary insufficiency. So possibilities are inadequate diet, malnutrition, elderly persons, inadequate dietary iron content, infants, diet that strictly excludes meat. Next reason is inadequate absorption. We will be having atrophic gastritis, malabsorption syndrome, gastrectomy, or intestinal recession or bypass, chronic diarrhea. So these can lead to inadequate absorption. Increased requirement. Whenever we are having a high demand for iron, that is physiological, period of active growth and development, premenopausal women and during time of pregnancy, and in chronic blood loss, we require more amount of iron. So if we are having any problem in any of these scenarios, we will be having iron deficiency anemia. That's why we will be having 1/4 of the population is suffered from iron deficiency. Clinical features of iron deficiency anemia. Here you should understand what is the function of iron, vitamin B12 and folate in IDA. So this will be keeping our nervous system healthy, maturation of epithelial cells, which is very essential for metabolic functions, and it will be also helping in erythropoiesis. So if you are having any deficiency in any of the component, that is iron, vitamin B12 or folate, these areas, that is nervous system, epithelium and other metabolic functions and blood synthesis, everything will be altered. So this is the key thing you have to remember. If you know this, then it is easy to remember what all are the clinical manifestations we are having. Clinical features of iron deficiency anemia. So in IDA, as we know, we will be having reduced oxygen carrying capacity, which may lead to tissue hypoxia. This tissue hypoxia may activate physiological compensatory mechanisms. So normal pathway is altered. So this alteration will be causing some sort of changes. These changes can manifest at different systems at different levels, as well as we'll be having some sort of troubles. So in the skin we will be seeing pallor of mucous membrane, and altogether due to lack of oxygen we will be having tiredness. Then if you are having shortage of oxygen, our lungs will be overstressed or overloaded, so they will keep working, so we will be having shortness of breath. Like that we will be having clinical manifestations. When it comes to gender predilection as well as age, we are having female predilection is more. The reason is two things. First one is mucosal changes, that is applicable for males also, but more than that, females will be having another scenario, that is gynecological problems, menstrual problems, pregnancy, etc. etc. So they are having more loss. So IDA will be more commonly seen on females. And we'll be having age group which may be related with 20 to 45 years. So it's a wide range only. So we have to be careful. Now we are moving towards our area, our specialty, that is oral manifestations. What are the things we will be seeing in oral cavity? So here we will be having angular cheilitis, diffuse or patchy atrophy of papillae of tongue, lingual varicosity, xerostomia, recurrent aphthous ulcer, glossitis, burning sensation, and tenderness. Now we are directly moving towards Plummer-Vinson syndrome, and later we will be discussing the treatment aspect as well as investigations, because in Plummer-Vinson syndrome also we are having IDA. So as you know, Plummer-Vinson syndrome, also known as Patterson-Brown-Kelly syndrome, sideropenic dysphagia. It is most commonly seen on middle-aged women or elderly women. Why we are having significance for PVS, or what all are the features of PVS? Let's have a look at this. Most common thing for PVS is IDA, that is iron deficiency anemia. Then we will be having dysphagia, difficulty in swallowing. It's also associated with esophageal web formation. So it is seen on postmenopausal women. And what is the significance is there is high chance for transforming this lesion into N leukoplakia or even squamous cell carcinoma. So it is suspected to be potentially malignant. That's why we are having more concern regarding Plummer-Vinson syndrome. Now it's a mnemonic, so it's like a story. I will read the story. Please note I have underlined so many areas. So these areas are the features. So if you remember this story, then it is easy to remember Plummer-Vinson syndrome. Once upon a time, there was a plumber living in Venice. His elderly wife was searching his belongings, where she found an iron pipe that she decided to swallow, and it was painful. First, the pipe came into contact with her lips, tongue, then it passed larynx, reaching the esophagus. When her husband came back, he saw her pale face and red beefy tongue, and he was shocked. Plummer-Vinson syndrome occurring on post-menopausal women, that is elderly wife, and it is due to iron deficiency, and major reason is of course iron deficiency anemia. And what will happen? They will be having dysphagia and odynophagia. So what are the clinical manifestations we will be having? Chelosis and angular stomatitis as well as glossitis. And then we will be having, and it's moving towards the internal area, esophageal web formation in the post-cricoid region. So that is another clue. Then what will happen? Clinically, we will be seeing a pale face with red beefy tongue. And he was shocked. What is the reason behind this shock? That is, there is a possibility for precancerous leukoplakia or even for squamous cell carcinoma. So that is the importance of Plummer-Vinson syndrome. So how we will be having diagnosis? So it's very simple. Investigations. We will be doing HB, RBC, MCV, MCH, MCHC, serum iron levels, serum ferritin, etc. We will be having reduction in all these values. So that is one possibility. Then we will be having normal blood smear. So in which you will be seeing normocytic normochromic 1 change to microcytic hypochromic 1. So what is the treatment of choice for both iron deficiency anemia as well as Plummer-Vinson syndrome? Oral supplement of, that is almost 150 to 180 milligram of iron administration in 2 or 3 divided doses. Then reticulocyte count will be increased within first week after the administration of elemental iron. That hemoglobin count may be increased within 2 to 3 weeks. There will be a gradual progression. So care must be given in this scenario. So these all are my references. You can read textbook for further information. So thank you. Thank you.